Dr. Watala, great to see you joining the call today. Looking forward to the interaction. And, I can see Chimba Sanga from CDC Zambia, and several other connections that have joined in on the call. Today we are having a very interesting, where we'll be looking at the management of TB infection. And we will look at all the aspects of TB infection management from the programmatic side, as well as the clinical side, as well as how to monitor. I'm just buying time to have a few more people join the call. I see ADCH has joined. It's good to see Arthur Davison joining the call. And let me also just check who else I can see. Several people have joined in. You are welcome to today's session. All right, just giving it a minute or so for a few more people to join, because from the start of the call, what will be discussed is laying the foundation for the other concepts that will come a little later. Right, I see Wezi Mtambo. Wezi Mtambo, how are you doing? How is Eastern Province?
Hi, Dr. David. Eastern is well, thanks.
Remarkable. Thank you so much. Dr. Webster Chewe, I see you as well. Dr. Walesa Ikoa, I see you as well. Thank you for joining. And please share the link as much as. All right, I'm just waiting for a minute or so that we have a few more people joining. And at exactly 14:30, I will introduce the subject matter expert taking us through the didactic presentation, and also the other subject matter experts. All right, so as mentioned, and as we saw in the invite that was circulated, today we are going to look at management of tuberculosis infection, abbreviated as TBI. And as we discuss this topic, we're going to have subject matter experts, including Dr. Rhehab Chimzizi, Dr. Angel Mubanga, Ms. Uchizi Chola, and several other subject matter experts, which include Dr. Linus Mwinga as well. I've seen the comment that has come in from through the chat box. No, I'm not just seeing doctors. I am seeing you as well. So Chakiwe, you're welcome. Just confirm where you're joining us from. Chakiwe? Chakiwe Njovu? Please unmute and just say hi to the network.
Hi, Doc. Thank you. Wanted to greet you.
Thank you so much. We're glad to have you join the call, and we value the support you continue giving us as ECHO Task Force. Right. So without further ado, allow me to introduce the didactic presenter for today. Is Dr. Mary Kagujje, who's currently the Deputy Chief of Party for the USAID Tuberculosis Local Organizations Network, which is implemented by the Center for Infectious Diseases Research in Zambia. She comes with a wealth of experience implementing the TB program, both at clinical as well as programmatic level. She is a medical doctor by profession and also a public health specialist with various accolades in the TB space. And I will be your facilitator. My name is David Singini. I'm also in the TB program. I support various aspects of the TB program in different capacities. at project level in the TB Local Organizations Network, as well as in one way or the other supporting the NTP. I'm also part of the contributors to the development of the TPT guidelines, which will be circulating very soon. So with that introduction, allow me to ask Dr. Kagujje to just greet the network and take us through the didactic presentation over the next 45 minutes. Dr. Kagujje, over to you.
Thanks, David. Good afternoon, everybody, and welcome to this session. As David said, we'll be discussing management of TB infection, which you will see abbreviated as TBI. Do take note that this is previously was called latent TB infection. So don't get confused. It's the same thing we're talking about. It's just there is a change in terminology. So the objectives of this presentation, thank you. One is to discuss TPT coverage globally and in Zambia, to describe the role of TPT in TB prevention, to outline the new updates to the TPT guidelines in Zambia, and where you see a star indicating new, you'll know that that's the new update, and then to describe the consideration for TB prevention in context of DRTB patients. So the outline is as such. We'll go through the introduction, the role of TPT in TB elimination, the populations eligible for TPT, the options available for TPT, the algorithms for latent TB infection treatment, and the considerations for implementation of TPT and M&E monitoring and evaluation. So before we go into the presentation, there will be a few questions which will be launched soon. And the first one is, what is the primary purpose of TB preventive treatment? Option A is to cure active TB disease. B is to prevent the transmission of TB to others. C, to provide relief from TB symptoms, and D, to treat dormant TB bacilli in the body.
Right, thanks for taking us through the poll question. The first poll question, it reads, what is the primary purpose of TB preventive treatment? Option A, to cure active TB disease. B, to prevent the transmission of TB to others. C, to provide relief from TB symptoms. And D, to treat dormant bacilli in the body. So I don't know why one of the answers is appearing to be in bold, but whether it's correct or not, I'm not sure. But maybe our ICT team can help us correct that before we move to the next poll question. All right, so the poll has been launched. Please select your best answer using the poll that has popped up on the screen. And do not send your answers in the chat box. We will see afterwards whether or not which of the options is the correct one. Okay, just to read the question once more, what is the primary purpose of TB preventive treatment? A, is it to cure active TB disease? B, to prevent the transmission of TB to others? C, to provide relief from TB symptoms? And D, to treat dormant TB bacilli in the body? So we had the majority going for D as the correct answer. All right, so the second poll question has been launched, which is asking, all right, we seem to be having a bit of a problem. Just a second. Right, the second poll question has been launched, and it says, how long is the typical duration for TB preventive treatment with rifampicin and isoniazid? How long is the typical duration for TB preventive treatment with rifampicin and isoniazid? So you choose the best answer. Option 1 is 2 weeks. Option 2 is, or rather B, is 1 month. C is 6 months. D is 12 months. I'll repeat the question. How long is the typical duration for TB preventive treatment with rifampicin/isoniazid? Option A, 2 weeks. B, 1 month. C, 6 months. D, 12 months. And you've been encouraged to pick the best answer. All right, so I'll just give it a few seconds as I also check if we've managed to correct the slides for the subsequent poll questions. All right, I'm already seeing comments in the chat box about poll question 2. So someone, Victor, says there's no answer, but there's probably something that is close to the truth. And it would be nice to have you select one option. Right, I've seen a hand from Dr. Chewe. I think I'll give you an option, a chance to speak at another time. Okay, I'll end the poll here and quickly launch the third poll question. And I'm seeing the pattern of the results is very interesting. The majority of the participants, thought C was the correct answer, which is saying 6 months. And we had 32% of the respondents who chose option 1, which says 1 month. And we had a few that thought D was the correct answer, and a few that thought A, 2 weeks, was the correct answer. So let me just quickly show, let me just quickly launch poll question number 3, and then we can get to the didactic presentation. So poll question number 3 reads, who is the most at risk and recommended for TB preventive treatment? Again, like poll question number 2, read the question carefully and pick the correct answer. So option 1 is individuals with current active TB. B is healthy individuals with no exposure. C, which has been omitted, I think will be corrected. It says TB, rather HIV-infected individuals with TB infection. That is option C. I apologize that it's just saying choice 3, but choice 3 is HIV-infected individuals with TB infection. That is option C. And then D says health workers only. So again, network, allow me to emphasize that option C is people living with HIV with TB infection, and it's not choice 3. Choice 3 is TB, rather people living with HIV with TB infection. That is option C. All right. So I'll give it a few seconds for 1 or 2 more individuals to give us their opinion or thoughts on what the correct answer is. And just to remind the network that I have no way whatsoever to know what option you chose, except the proportions of who chose which answer. So I'll repeat the question. Who is most at risk and recommended for TB preventive treatment? Option A, individuals with a current active TB. Option B, healthy individuals with no exposure to TB. Option C is people living with HIV with TB infection, and D is health workers only. All right, again, encourage everyone to respond through the polling system, and the answers that are put in the chat box will not be accounted for. All right, so I'll end the poll here and share the results. So 69 people out of the total network participated in this poll. Again, I apologize for option C, which is a bit of, has a mistake, but that will be corrected. So the majority thought C was the correct answer. People living with HIV with TB infection are the ones most at risk for TB preventive treatment. Others thought healthy individuals with no TB exposure was the correct answer, while a few thought health workers only was the correct answer, and another 7% thought individuals with current active TB are the ones that require TB preventive treatment. So I'll end this pause now and hand over back to the didactic presenter to take us through the presentation.
So thanks, David.
Dr.
Yeah. So globally, TB is the single leading cause of death from an infectious agent. And you may ask, but we know that maybe diarrheal diseases kill more people. But when you're looking at diarrheal diseases, you're looking at different organisms. But if we're looking at a single organism causing death, that's TB. And among people living with HIV, it's also the leading cause of mortality. In fact, about 25% of all the people dying that are HIV positive, it's due to TB. And in Zambia, it's one of the top 10 causes of death as well. So, give me a minute, please. What is TB infection? And this is why we are here today. So this is a state of persistent immune response to stimulation by TB antigens without evidence of clinically manifested TB. And simply put, you have inhaled the TB bacilli, and they're in your body. Your body has managed to wall them off. You're infected, you have an established infection, but you don't have signs of active TB and you do not feel ill. So typically as well here, you would have no TB bacilli detectable in your sputum, and you would have no radiological changes due to TB. You have TB, but it's not causing any effect to your body. So usually some of these people can develop active TB in future. So on average, of those who develop active TB, and this is among adults, 5 to 10% who continue who develop latent TB infection will develop active TB over the course of their life. But the risk of developing active TB is highest in the first 2 years following infection, and it wanes down after that. In the HIV-infected population, it's important to note that the risk of TB is 10% every year. And we are seeing 10% in the un-HIV-infected population. In the HIV-infected population is 10% every year. And in fact, people living with HIV are 21 times more likely to develop active TB following infection compared to the HIV-negative population. And I think this clearly explains why we've been putting so much emphasis on TPT initiation in people living with HIV. We'll talk a little bit more about this later. So this is really just an explanation of, the differences between TB infection and TB disease. As we said, you have an infection, you do have TB in your body, but it's not making you sick and you don't have any symptoms. Because it's been walled off and the body has contained it, you can't spread it. But later, it can advance to TB disease. if you have TB disease, if you look at the illustration here, we have the bacilli here and they've been walled off. But on the opposite side, where we have TB disease, you do have the bacilli and your wall has broken down and they've been released to different parts of the body. So certainly you will feel sick and you have symptoms of TB, and you can spread TB to other people, and it can cause death if not treated. I think the most important thing to note is when you have active TB, usually your sputum will be positive for TB, but in some cases it may not be because it may be little TB, which we call postbacillary TB. But in the other instance, you may have chest X-ray changes due to the TB. So it's important to note that at a global level, we had over 10.6 million people who fell ill with TB. And of these, 6.4 TB accessed care, which is a decline. Now we are having a conversation about TB. Why do the 4.2 million people matter? Simply because untreated people spread TB. They'll pass on the infection to other people. So the more people you don't have treated for, the more people you have that are not treated for TB, the more you're spreading TB in the community. And we've been making great progress with TB, with control. However, the COVID pandemic took us back so many times because of the different impact that it had on access to TB services. And then now when we go again to the global targets on TPT start, we noticed that we had said that between 2018 to 2022, we'd have over 30 million people initiated on TPT, and we only managed to initiate 12.5 million. Now, if we break it down to the different populations eligible for TPT, you find that among people living with HIV, we exceeded the target. Among the household contacts to TB, under 5 household contacts, we achieved 40% of the target. And among household contacts more than 5 years, we only achieved 3% of the target. So that's at a global level. But what do we see? We'll come shortly to what we are seeing in Zambia. So in Zambia, we have about 60,000 people developing TB every year. And if you try and then say, okay, in a day and in minutes, how many people do we have developing TB? You have about 1 person falling ill with TB every 9 minutes. And our incidence is estimated at 307 per 100,000 population. So this makes it very important because 60,000 absolute numbers is quite high for a number of diseases, especially when you have over 7,000 people dying from the disease, estimated 7,000 people that die from TB every year. And in Zambia, we managed to initiate in 2020, we managed to initiate over 160,000 people on TPT. So we were talking about the TPT targets at global level. How have we done at Zambia? So you can see that among people living with HIV, we've done a fantastic job. We've exceeded our target threefold, even up to fourfold. But among under 5 contacts to TB cases, we have not done a very great job. In fact, our best performance is not even 50%. Yes, we have a few targets among contacts above 5 years of age, but they're not included here because we did not systematically collect the data. So what's the role of TPT treatment in TB elimination? So let's look first at this graph. So you will note that we do have NTB targets, and these are primarily aimed at reducing TB incidence, reducing mortality, and catastrophic cost of TB to certain determined values. And when we look at a global level, we are saying we should end TB by 2035. But in Zambia, we said, you know what, we really need to end TB quickly, and our aim in Zambia is to end TB by 2030. So in essence, if we were to end TB by 2035, Before 2025, we should have a decline in TB incidence by 10%. And we should also have a decline every year. And after 2025, we should have a decline of 17% every year. And this would require us to accelerate the use of the currently available tools, one of which is TPT. But what we are seeing is at a global level, our reduction in the TB burden only stands at 1.5% per year. Never mind that we've had some of this progress derailed by the COVID pandemic. Now, we said earlier that the risk of progression from TB infection to active TB is 10% per year in people living with HIV. But we know that now we have TPT and we have effective regimens which have an efficacy of about 60 to 90%. And of course, if you use them in combination with ART among the people living with HIV, we know that their protective effect is enhanced. Now, we are glad that we live in an era of test and treat, and most people are accessing ART. And ART does, in fact, offer some protection against TPT, but it doesn't fully protect, it offers some protection against TB, but it doesn't fully protect us from TB. And that's why you will see a person established on ART, but is developing TB. And that's where TPT comes in so that we have a synergistic effect. So now these are just a few modeling studies to try and show the impact of TPT on TB elimination. And these are from very select settings. When you look at your y-axis, you'll see percentage reduction in active TB instance with TPT compared to no TPT. And these are studies from different settings. These are modeling studies. You will notice that on average, and do please take note that these TPT studies were in very select groups. We had TPT at the TB incidence reduces by about 25%. And of course, you also have some settings where the TPT incidence reduces close to 100%. So certainly by scaling up TPT in the populations where it's needed, we can have a very big dent on TB, of course, coupled with other, TB control interventions. So now, yes, providing TPT is a great start, but we need to be systematic about it. We need to certainly make sure that we are not looking at it as just TPT, but we need to look at it as a program. And, that's where the term programmatic management of TB infection comes in. We should be in position to identify and test those who are at risk for TB. Because if we focus just on, people living with HIV, yes, we will saturate, but how about the other groups? So we need to have a very robust way of looking at this. And then we also need to deliver effective and safe treatment. And we certainly need to be able to monitor the process and see how we are progressing and put in interventions as necessary. So what are the populations eligible for TPT? So we do have adults and adolescents living with HIV. And really here for adults and adolescents who are, 10 years and older, irrespective of previous TB treatment, please initiate on TPT. That's the same for infants and children who are living with HIV. If they are more than 1 year, please initiate TPT. Now, there is a bit of a caveat. So in essence, what we've said is all people living with HIV should receive TPT. But there is a caveat. If a child is less than 1 year, the risks of TPT will outweigh the benefits of TPT if they don't have an additional risk factor. And that's why you see the emphasis here. Infants aged less than 12 months living with HIV who are in contact with a TB case, those should be given TPT. If they're not in contact with a TB case, please do not initiate TPT. And again, you will see somewhere that we are saying, let's do symptom screening. And this is important. Please never start a patient on TPT without screening them for active disease. And we will talk about this, that a little bit more. So of course, even among pregnant women that are living with HIV, they should still get TPT, but do take note that one, maybe first is pregnancy will reduce your immunity. So your risk of TB is actually amplified if you're HIV positive. So yes, we need to give TPT in this group, but we must give it after the first trimester. Why? Because if we administer it in the first trimester, the risk to the baby and the pregnancy will increase. And, you'll start to see things like low birth weight, babies who are struggling to thrive, even a risk of, the mother, losing the baby will increase. So please, TPT should be given after the first trimester. So we do have other populations that are eligible for TPT, and I'll take you through this. So by and large, what we've seen is that among people living with HIV, we've done a great job, but I think there is a lot of work to be done in the HIV negative populations. So one is we have HIV negative infants and children who are household or close contacts to TB cases. And we've defined that close contact is a person who's been living in a shared or enclosed space, such as a workplace, a classroom. I don't expect children to be at workplaces anyway. So classroom for an extended period during the day with a person who has active TB in the past 3 months. And we are focusing on the past 3 months because we know that TB has a chronic course, and usually the symptoms will not be so acute. So people take time to present to the health facility to get diagnosed with TB. But before they are diagnosed, they are transmitting. That's why we're saying a person who's been, in close contact in the past 3 months. And then a household contact, of course, the same definition. It's just that they're staying in the same house. So we have other HIV negative populations that are eligible for TPT, minors and ex-minors with silicosis, then close and household contacts of birth-confirmed TB cases. Remember that earlier on my previous slide, I focused a lot on under 5 children. Then here we are saying all close and household contacts. And as we go on in the presentation, you'll see slight differences in the algorithms before you initiate TPT. Then patients receiving immunosuppressive treatment, patients with chronic kidney disease, especially those who are on dialysis, and then incarcerated populations and healthcare workers. So just to share a little bit on some of this population. So among close and household contacts, we noticed that because the very young children don't have a fully established immune system, once they contract the infection, the risk of progression from infection to disease is high. We see that a child who is less than 1 year, if they get infection, there are 43% of them, their chances of progression to TB disease stand at 43%. Well, we see that that's only 24% in children who are slightly older. And also children that are under 5 years, they're more likely to develop complicated forms of TB, like TB meningitis, TB involving the bones. So what we are saying is that we must treat this as a special population, and we have to make sure that we do provide TPT to them. Among adults, I think it's adult and adolescents who are close contacts, following infection, 15% of adolescents would develop TB over their lifetime, and then for adults, it's 5 to 10%. So again, all adult close and household contacts should be screened for TB and offer TPT once TB is rolled out. The thing to note is look at the differences in risk, and I think you can appreciate much why we emphasize initiation of TPT in under 5 children. But then again, if we are speaking about ending TB in Zambia, we need to look at all the people at high risk. And certainly this is why our eligibility criteria was expanded since the previous guidelines to accommodate for the adolescents and adults. So among the incarcerated populations, we know that generally the setting is extremely crowded. And I think that's very nicely illustrated in the photo, where you see that there is extreme overcrowding. So it's a bit difficult to apply your typical preventive measures. And for those reasons, we see that in this population, the prevalence of TB is 3.5 times higher than that in the general population. Suffice to say that this is a great improvement from where we were in the last prevalence survey that had been done in prisons around 2010, it was around 18 times higher than the general population. So yes, much progress has been made, but this is still a problem. And of course, also the current prevalence for HIV in prison stands at 14.3%. Again, a big improvement from what we saw previously. So we see that in prison population, again, because we have high rates of HIV, which we have already discussed is a risk factor for TB, stressful conditions, overcrowding, undernutrition. We know that typically in this setting, this is a good setting for people to progress because there are several risk factors within this setting, both for getting the infection and also getting the disease. And that's why we say that for inmates, we must give TPT, yes, if they're HIV infected, they qualify for TPT. Also, if they are sharing a cell with an index TB case, regardless of HIV status. You know, if you're looking at this, you can estimate that a cell will probably have over 50 people. So these are people that will greatly benefit from TPT after we've rolled out active TB. And HIV negative inmates with other risk factors. So for example, I might not be sharing a cell with a person suffering from TB, but you know, I could be having diabetes. I'm an inmate and I'm having diabetes. That would then make me eligible for TPT. So take note that if they're HIV negative, either they are contact to an index case, they're sharing the cell, or they have additional risk factors. So we also have the minors and ex-minors, and here the focus is on those who have silicosis. So minors with silicosis are at increased risk of suffering from getting TB disease, irrespective of their HIV disease. And this is because silicosis has been associated with impairment of certain components of the immune response that are key to, keeping the TB dormant. So it will interfere with the macrophage functioning and also the dendritic cells, which are key to the immune response to TB. So, and that's why we say that minors and ex-minors should also be given TPT. We also have the healthcare workers. And as a healthcare worker, probably you're based at the chest clinic and you're seeing patients who are coming in with diagnosed TB. But you could also be sitting at the OPD. And here, you know, when you're sitting at the chest clinic, you know that people have TB. So you're more likely to pay attention to infection control. But if you're sitting at OPD and you're having all these patients coming through with coughs, you will be exposed to infectious patients. You just won't know if they have TB or not. Sometimes you might not know. So again, even in other departments, we see healthcare workers being exposed to infectious patients. But also we may have some healthcare workers who have an immunosuppression. So it's currently recommended that we do have biannual screening for healthcare workers, and we provide a TPT for those that have latent TB infection, and anti-TB treatment for those who have active disease. So what are the different options available to us for TPT? So one, I think most of us may be familiar with this. We have isoniazid, and we've been using this for a long, long time now. So, we can give this to all eligible populations. And typically in adults, the dose is 5 milligrams, and in children it's double that. And you can give up to a maximum dose of 300 milligrams. So this is typically taken once a day and is given for 6 to 9 months. And in our setting, we recommend that isoniazid be given with vitamin B6. And this is because we know we have high levels of malnutrition. So it's imperative that we give B6 to minimize the peripheral neuropathy that will arise as a side effect to isoniazid. We also have another option, which is rifampicin and isoniazid, and this is commonly called 3HP. So again, this is given to all the eligible populations, but take note, we don't give it to children that are under 2 years. So again, isoniazid, the dosage, we stratified this into 2 to 11 years and over 12 years. Take note of the different dosages. Again, the different dosages of rifampicin. The maximum dose is for INH is 900 and rifampicin 900. So this is taken once a week for 3 months. So your patient, your client will be taking 12 doses of the drug. Please take note that again, this is given with vitamin B6. I think in our setting, maybe the NTP will comment later, we are having this as combination fixed dose treatment, so combination drugs, so the pill burden shouldn't be that high. Remember 3HP, we're not giving it to children that are less than 2 years. So then we also have isoniazid plus rifampicin. Do take note that, if you've treated a TB patient before, you'll notice that, this is what we'll typically give a TB patient in the continuation phase. But it's also a TPT, an option for TPT, and we give it to the different eligible groups. The dosages, again, 5 milligrams and double the dose in children, and for rifampicin is 10 milligrams and 15 milligrams. So this is taken once a day for 3 to 4 months, and again, given with B6. So you may ask, why am I saying 6 to 9 months, 3 to 4 months? This is because we know that there may be a few doses that are skipped, and the extended duration is to account for those additional doses. Then we have rifampicin plus isoniazid. And again, this one is given to the different eligible groups, but the people have to be above 13 years of age. So again, take note of the dosages. I must say, so this is, take note, this is 5 milligrams per kg, and rifampicin is 10 milligrams per kg. The maximum dose for INH is 300 milligrams, and for rifampicin is 600 milligrams. I must apologize, we only wrote the adult dosages. We didn't write the children dosages, but you will certainly find those in the guidelines. So this is once daily. So a patient will take the drugs for 1 month and they have finished. Again, please give it with vitamin B6. So we're talking about these options, and if you take note, these are options for drug-susceptible TB. How about contacts to drug-resistant TB? How should we deal with them? So you will notice that we had this again in the previous guidelines, but we've included it in these guidelines and provided a little bit more clarity so that you're better guided as you're making the decisions. And I'll read this as appears in the guidelines because it's extremely important. The decision to treat contacts of drug-resistant TB patients should be made in consultation with a clinical expert committee. You all have clinical expert committees in your provinces, and in some districts, if you don't know how to get in touch with the clinical expert committees, again, the provincial district TB focal point persons would be useful for that process. But we certainly have to do individualized risk assessment. And the way the CEC will make a decision is they will look at the intensity of exposure. They will look at certainty of the case source. They will look at the information that relates to drug susceptibility testing. So take note that these are contacts to drug-resistant TB patients. So they are the background is that this contact, the index patient has resistance to some drugs. So of course, in this instance, because you're now giving TPT and the TPT needs to be effective, we are then saying that you need to have reliable information on the drug susceptibility profile of the index case and of course the potential adverse events. So again, if a decision is made, there will be close monitoring of the patient. So strict clinical observation. So here in this case, the TPT will be given under DOT, and the patient will actually be followed up to 2 years post TPT completion to check and confirm and to rule out development of active TB in the process. And in this case, again, adherence counseling must be given at start of treatment and during the course of treatment, because we would hate for this patient to fail to take their drugs and to not take their drugs on a consistent basis, develop active TB and continue taking TPT before we figure that out. So it's extremely important that we pay attention to adherence so that we optimize the impact of the TB preventive treatment. But if in any case we were to have breakthrough TB, which is extremely rare, then we would pick it up early and provide appropriate treatment. So the drug that is going to be used for TPT among the DRTB contacts is levofloxacin, which is given daily for 6 months, and we have different dosages for the different age groups. Again, the thing to remember here is we shouldn't leave here saying that we are going to start initiating DRTB contacts on TPT at our facilities. This decision would be made in consultation with a clinical expert committee that will request for particular information to make a decision on whether you should start on or not. And this is all based on the fact that we should optimize the benefits compared to the risks of certain treatments. So what are some of the considerations that you need to make before you start a patient on TPT? One is the drugs we've gone through, rifampicin, isoniazid, rifapentine. These are also drugs that we use for treatment of active TB. And if you may remember anything from on treatment of active TB is that we cannot use monotherapy. So it's always important to exclude active TB before we initiate TPT because we are trying to prevent monotherapy. So make sure you have ruled out active disease before initiating TPT. So how do we then do it? So typically, we will do symptom screening. So symptom screening has a very high negative predictive value. So we'll tell you most of the patients that have TB, it will pick up. Most patients will have symptoms. But where you have a chest X-ray available, please also use the chest X-ray to support your screening process because there may be some patients who are missed on symptom screening, but will be picked up on chest X-ray screening, but those are very few. Then we have a group of patients who might be asymptomatic. So you do your symptom screening, you do your chest X-ray, and it's not suggestive of active TB, but they actually have TB. And for this group, we recommend universal testing, preferably with a gene expert. So these are all PLHIV with advanced HIV disease, PLHIV with documented contact to a TB patient in the past 1 year, those who had active TB treatment in the past 2 years, ART treatment failures, PLHIV returning from ART interruption of at least 1 year, and all under 5s with an HIV positive result. So again, there are some contraindications to TPT. So if you have active or suspected TB, please don't start a patient on TPT. If we have known or suspected hypersensitivity to isoniazid, if you have active or chronic hepatitis, alcohol abuse, and alcohol abuse, we are looking at, men consuming over 28 units of alcohol and women 21 units. I think a fair equivalent is that, your Mosi or Castle would have at least 3 units. So if you're a man, you're looking at not consuming more than how many? Not more than 8? Yeah. Units, not more than 9. I hope the mathematics is right. Anyway, not more than 8 bottles of alcohol. And of course, it's less for women because the threshold is 21. Then existing peripheral neuropathy. Remember, for most of these combinations, we've seen that INH is part of them or the only drug in the regimen, and it's associated with peripheral neuropathy. Patients with history of convulsion, psychosis, and some on concomitant medication. Those are different drugs, and for most of them, you'll notice that most of these, you'll notice that for most of these, the different INH regimens will either increase or decrease their bioavailability. So again, just for purposes of being cautious, there are some patients, typically we don't initiate TPT, we don't request for LFTs before starting TPT, but there are some categories of patients for whom would like to make sure that we are, comfortable before initiate TPT. And those are patients with history of chronic liver disease, regular use of alcohol, HIV infection. So sorry, I'm seeing this here, and I think maybe later I'll ask one of the experts to comment on this. Age over 35 years and pregnancy or postpartum period. So here, please request for liver function test before starting treatment. So if there is anything you should take away from this presentation is rule out active TB before commencing patients on TPT. So let's look at the different algorithms that we are using for initiating TPT among patients that are eligible. So we'll start with adults and adolescents living with HIV. So here, this algorithm is focused on people above 10 years of age, 10 years and above. So again, the first thing you try to do is to determine, do they have any of the TB symptoms? And the question is, if the response is yes, then you investigate for TB. If when you do that, you have your gene expert coming back as positive or negative. If it's positive, it's straightforward. You must treat them for active TB. But if it comes back negative, then you should request for a chest X-ray. Remember, these are patients that came in with symptoms. So gene expert is negative, we are requesting for a chest X-ray. Is a chest X-ray suggestive of TB? Yes, treat for TB. If it's not suggestive for TB, treat according to the clinical diagnosis. Now, on the other hand, we have patients who will have no TB symptoms. If they have no TB symptoms, of course, there will be those that we talked about that are eligible for universal TB testing. So we'll look at that shortly, but there will be those that are not really eligible for universal testing. So if you have IGRA available in your setting, so IGRA is a test that, this is interferon gamma release assay, or the MAN2 available in your setting. These are tests that are used to diagnose TB infection. If you have them available, then you will test, the person will test. If it's positive, it's straightforward. We will move to this arm. If it's negative, then your next question has to be, is it possible that this is due to allergy? That people actually have TB infection, but the result is coming out negative, probably because they are severely immunosuppressed. They have they have malnutrition. So those are the kinds of questions you would have to ask. But if IGRA is not available in your setting, and for most of us, we fall here, take note that non-availability of TST or IGRA should not stop you from evaluating for initiation of TPT. And that's because we've already said that one is people living with HIV at high risk of progression to active TB, but also two is TB continues to be the leading cause of death among people living with HIV. So for those reasons, it's imperative that we are looking at this from the benefit angle. The benefits will outweigh the risk. So you will assess for the contraindications, which we talked about earlier. And of course, they've also been listed here for you. If there are no contraindications, start TPT. If there are contraindications, don't provide TPT. For the people that are eligible for universal testing, you will go ahead and test them. If the test is positive, treat for active TB. If it's negative, if you have chest X-ray, use it as well. If both are negative, continue to assess for the contraindications and follow the algorithm as such. Then we have children between 1 year and 10 years. So again, remember children, we have some slight variations in the presentation. Yes, we have cough, fever, but we will have things like anorexia again in children. We will have things like poor weight gain, reduced playfulness, fatigue in children. So look, if you pay attention, the symptoms are a little bit more in children. So again, the criteria is more or less the same. They're symptomatic, you investigate for TB. And again, remember, you will note that children usually will not be positive on GeneXpert. Children are more likely to be clinically diagnosed than adults. So go ahead and do that chest X-ray. If it's suggestive of TB, go ahead and treat for TB. If it's not suggestive of TB, treat according to clinical diagnosis. Assess, and then if they are not symptomatic, assess for contraindications to TPT. If they don't have any, start TPT. Now, the thing is, usually when a person is symptomatic, even if you've ruled out active TB, you want to be sure that really they don't have TB. So it's always great that you wait for whatever is, if you're saying we're treating according to the clinical diagnosis, wait and assess response to treatment, wait for the symptoms to resolve, and then you can then comfortably make a decision to initiate TPT. Remember, starting TPT is not an emergency, so it's a situation where you need to be comfortable that you're giving your patient the best option. So then we have the other HIV risk groups. So here we'll look at HIV negative adolescents and adults and others and other risk groups greater than 10 years. Again, this is more or less the same. The only one thing that you pay attention to, so I think we'll not focus on the yes arm because it's a bit straightforward, but we'll focus on the no arm. If they don't have any of the symptoms of TB, you find out if you have IGRA in your setting. So if you have IGRA in your setting, you go ahead and test. If it's positive, then you want to be sure that it's not active TB, so you request for a chest X-ray. If the chest X-ray comes back and it suggests any abnormality, let's do further clinical evaluation for TB and other diseases, and based on what we find, then we treat appropriately. If it says no abnormality, assess for contraindications, and if there are none, you start TPT. If IGRA is not available, so I have gone to this family and I'm making a decision to initiate people who are over 10 years of age on TPT. If IGRA is not available, let us request for a chest X-ray. And again, based on the chest X-ray, you will then make a decision on if you're going to initiate TPT or not. I hope that's clear. So among those who are less than 10 years of age, we are going to rely, if they have no symptoms, we will primarily rely on symptom screening. If they have no symptoms and they have no contraindications to TPT, we will start TPT. If they have any, you don't start. Again, the algorithm for if they have symptoms of TB is very similar to what we discussed previously, and we'll not go through that again. As you go through your guidelines, pay attention to the footnotes in the different sections. They will define what your poor weight gain is, and they will also talk about the different regimens. So there's a few additional considerations that we need to have in mind as we implement TPT. So one is that among people living with HIV, we will repeat TPT every 3 years. And why do we do this? The effect of TPT lasts on average 3 years. Some literature would tell you 5 years, but it's 3 to 5 years. And that protective effect is much less in a high burden setting. And that protective effect reduces after you complete treatment. It continues to reduce as you complete treatment. So because we are living in a high burden setting and we have ongoing TB exposure, it's recommended that we repeat TPT every 3 years among people living with HIV. So I know if you paid attention earlier, you noted that we had high numbers of people living with HIV initiated on TPT. After 3 years, those people will be eligible depending on when they started. A few safeguards as well is we have what we call breakthrough TB. A person was screened for TB at baseline, they didn't have symptoms of TB, but then later on they developed TB. This is very rare. And in fact, the study we did in Zambia, when we analyzed routine data, it was 0.5%, less than 0.5% among a big number of individuals, a very big number of individuals. But most of these are people that had symptoms at baseline, but had not been adequately screened for TB. And a big pool of the others had advanced HIV disease. So yes, it can happen, but it's very rare. But we want to be cautious. So every time a person that is on TPT comes for review, we need to be able to screen for active TB. We should ask about the symptoms of TB. So regular follow-up for early identification of TB is important. And patients who develop active TB during TPT, of course, one, you want to do a gene expert test to guide, and based on the gene expert results, you'll start treatment. If it's rifampicin resistance, of course, you're going to treat in a different way. And if it's isoniazid resistant, using the current gene expert that most of us have access to, you won't pick that up. So you need to send your samples to the culture labs for culture and DST. The other thing to have in mind is drug-drug interactions. And this is especially important for the people living with HIV, and again, as we'll see very soon, among patients who are being treated for malaria. So we know that rifapentin, we know that the rifamycins actually, they increase the metabolism of the other drugs. So, but of course we know that rifampicin actually does that much more than rifapentin. So the recommendation is if a person is taking rifapentin-based regimens, we don't have to adjust the dosage of DTG and TAF. That's because the decline is not significant enough to warrant that. But for rifampicin, it's slightly different. So if you're taking your 3 HP or you're taking your 1 HP, you don't have to worry if a person is taking a regimen that has DTG or TAF. Now, if you're taking rifampicin-containing regimens, they shouldn't be given with TAF because of the decrease in bioavailability of TAF. And also, if a person is on a DTG-containing regimen, we need to double that dose of DTG. Now, take note that for DTG and TAF, we are doing, taking different actions depending on if it's rifampicin or rifapentin-based regimens. However, if a person is on here is on second-line treatment, please don't use 1 HP or 3 HP because of the extent to which the protease inhibitors will be reduced, their levels will be reduced. So in those categories of patients, we use 6 months of isoniazid. So for anti-malarials, again, the rifampicin and rifampicin reduce the bioavailability of artemisinin-based combination therapies. And you know that for most of our patients that are diagnosed with malaria, we initiate them on Coartem. So of course and the extent is quite significant. So if a patient is diagnosed with malaria prior to commencing rifamycin-based TPT, please delay the TPT until malaria treatment is completed. For patients already on rifamycin-based TPT, so I have already started my 1 HP, my 3 HP, or my rifampicin and isoniazid, and I get malaria, please stop the TPT, treat the malaria. Once you complete malaria treatment, then you resume the TPT. And the consideration here is that, again, malaria is what will kill you. So let us deal with that malaria and then resume the TPT after. So for TPT to remain effective, it's essential that the TPT course is completed as indicated. So patients need to be educated about the possible side effects of TPT, and these are commonest in the first month of treatment. Why this is important is because then it gives a patient a more active role in their treatment, and also it allows for these side effects to be reported as quickly as possible. So some of your commonest will be increased appetite, headache, itchy skin, joint pains, diarrhea, nausea, stomach pains, decreased libido or energy, and of course, in some of the patient settings, we've been seeing the skin rash. Now, again, these adverse effects are mainly associated with rifampicin and isoniazid. So for isoniazid, again, we might have a symptomatic elevation of the liver enzyme. Of course, we know the peripheral neuropathy, pellagra, and potential hepatotoxicity. Then for rifampicin, you have cutaneous reactions, hypersensitivity reactions, GI intolerance, and possible hepatotoxicity. So let's make sure that before we start TPT, we adequately screen people for the contraindications to INH. And if the group has been listed among the ones where we need to be cautious and do baseline liver function tests, where available, please go ahead and do them. So in terms of monitoring patients on treatment, among people living with HIV, let's try as much as possible to conform the TPT dispensation to the DSD model, so that if a person is coming, every 3 months for their ART refill, you give the TPT as such. If they are coming every 6 months, you give the TPT as such. But in other populations, we'll do monthly for the first 2 months and every 2 months thereafter. And the patient should be informed to inform the healthcare workers anytime they become aware of side effects. Again, adherence is very important. All clients should adhere to the full course and complete their treatment. So in terms of the M&E, we need to be able to monitor the activities that we are implementing to support. If you will note earlier, we mentioned that we need to be able to identify the risk populations, adequately screen them, start them on TPT, and monitor the process. So again, key consideration is to what extent are we screening people? And of those that are eligible for TPT, how many have actually been initiated on TPT? We do have some standard TPT recording and reporting tools, TPT cards, TPT register. Of course, a contact tracing register becomes important because this is where we are getting one of the high-risk groups that are eligible for TPT. We We have a TPT quarterly reporting tool and a TPT cohort report form. And we use this cohort report form to try and determine completion rates because we want to optimize the impact of the TPT, so people must complete treatment. So this is the quarterly TPT prevention, therapy, screening, and enrollment reporting tool. And this is the cohort report form. So thank you. That's the end. And again, I need to acknowledge the various people that contributed to the development of these guidelines, most of whom are on this call. Apologies, they are not explicitly mentioned here. David, that's the end. I would like to hand over back to you.
Right. Right. Thank you so much, Dr. Kagujje, for that very, very enlightening talk on TB preventive treatment and various considerations for TPT in different eligible populations. And quite interesting was to see that now we have regimens that require just a shorter duration of treatment to achieve the same results, which is very, very encouraging for us in the TB program. It was very interesting when we were looking at one of the poll questions. I think maybe we could actually go through the poll questions and see if there has been a shift in the opinions. So the first poll question reads, what is the primary purpose of TB preventive treatment? What is the primary purpose of TB preventive treatment? Option A, to cure active TB disease. B, to prevent the transmission of TB to others. C, to provide relief from TB symptoms. And D, to treat dormant TB bacilli in the body. All right, there we have it. That is our first poll question. I will launch it and invite you to give us your thoughts on what you think is the correct answer. I'll repeat the question. It says, what is the primary purpose of TB preventive treatment? TPT. A, to cure active disease. B, to prevent the transmission of TB to others. C, to provide relief from TB symptoms. And D, to treat dormant TB bacilli in the body. All right, very, very encouraging response from the network. Several people were almost at 50% of the network submitting your poll. And again, for emphasis, just to mention that when you submit a poll, none of us, including the IT team, can see what answer you chose, but we'll merely see the proportions of people that chose each of the options that have been provided. All right, Dr. Kagujje, I'm sure you can see interesting trends on your screen in terms of the voting. I will end the poll now and share the results and ask you to comment on the results from this poll. The majority of the people that polled thought D was the correct answer, that the purpose of TPT is to treat the dormant TB bacilli in the body. Dr. Kagujje, your comment?
So thanks, Network. So just to emphasize, if you remember the slide on differences between active TB and TB infection, you will note that people who have TB infection cannot spread the disease, and it's because the infection has been walled off, so they cannot spread. So that wouldn't be a correct answer. And to provide relief from TB symptoms, if a person has TB symptoms, that would mean they have active TB and they need to be treated. If you were to treat them with TPT, you would actually not be adequately treating them. So that would also not be a correct answer. Then to cure active TB disease, again, as we've said, we cannot use, remember, TB treatment has 4 drugs during the intensive phase and 2 drugs during the continuation phase. Now, if you're using just 1 or 2, you're not treating the person correctly and you're encouraging resistance. So option A, B, and C are not correct. The only correct option is to treat dormant TB bacilli in the body.
All right, thanks for that. Very, very interesting. And let's go to the second poll question we had. I think this one had very, very interesting responses. But let's see how this goes. Option, it says, how long is the typical duration for TB preventive treatment with rifampicin isoniazid, or rifampicin combined with isoniazid? And here, please choose the best answer. Option A says 2 weeks. B says 1 month. C, 6 months. D, 12 months. Again, how long is a typical duration for TB preventive treatment with rifampicin/isoniazid, the combination of rifampicin and isoniazid? So again, choose the best answer. Option A is 2 weeks. B is 1 month, C is 6 months, D is 12 months. This one was the most interesting poll that we had. Very interesting results coming in, and 2 of the options are heading, are moving neck to neck. And so we still have varying opinions even after the presentation. All right, so in the interest of time, I will end the poll and share the results. So we had the majority, 55% of the respondents saying B was the correct answer, which is 1 month. Then we had 41% that thought C, 6 months, was the correct answer. Again, Dr. Kagujje, your comments on this?
Okay, so you will remember that we had 4 options for TPT. The first one, we talked about isoniazid, and isoniazid only is what's given for 6 months. Now you'll take note that our question says rifampicin and isoniazid. So if you're talking about rifampicin and isoniazid, then you're certainly looking at either 1 month or 3 months. We don't currently have any TPT option for 2 weeks, and we don't have a TPT option for 12 months. So here the correct answer is 1 month.
Very, very interesting. And I saw earlier on when we shared this poll, a number of people did write in the chat box saying that there was no answer for option, or rather for poll question 2. And I hope this has helped. Remember, rifampicin isoniazid is where the trick was. And of the available options, like Dr. Kagujje has mentioned, 1 month is the best option amongst the provided responses, potential responses. So let's go to the third and last poll question. This one reads, who is most at risk and recommended for TB preventive treatment? Who is the most at risk and recommended for TB preventive treatment? Option A, individuals with a current active TB, or rather individuals with TB disease. B, healthy individuals with no exposure to TB. B says healthy individuals with no exposure to TB. C says people living with HIV and TB infection. C says people living with HIV and have TB infection. And D says healthcare workers only. So again, read the question and then pick the best answer of the 4 options provided. All right, very, very interesting poll. Otherwise, we can see that learning has actually taken place based on the voting pattern. Just give it a few seconds again, just to hit the 50% mark, and then I'll share the results. All right, there we go. So I'll end the poll now and share the results. So we have 74% of the network opting for C as the correct answer, which is people living with HIV and those with TB infection. And then we have 13% thought healthy individuals with no TB exposure needed TPT, and then the rest were divided between option D and A. Again, Dr. Kagujje, your thoughts on this poll?
Yeah, so the first option is individuals with active TB. Please do take note. We must never give TB preventive treatment to individuals with active TB. If you have active TB, we are no longer at the point of preventing. We are now at the point of curing. So we would give you a full course of anti-TB treatment. Then healthy individuals with no exposure to TB, the use of TB preventive treatment is to prevent TB infection from progressing to disease. Take note, it does not prevent you from acquiring the infection. So B would be a wrong answer. People living with HIV and TB infection, that's correct. Healthcare workers only. So this response would be correct if we had just said healthcare workers. But by adding only, we excluded the other eligible groups, and that's why this is not a correct option. So the correct response is C.
Right. Thank you so much for participating in the polls. At this point, allow me to utilize the last 10 minutes of the call to have a few questions or comments regarding the conversation on TPT. I did note earlier on, people were like, but we're supposed to be talking about the guidelines, what's going on? I hope now you have realized that we have really focused much on the new guidelines. There are some changes that have been introduced in the new guidelines, but they're not so many compared to the previous guidelines. Key things to note is the recommendations for HIV negative individuals. We're also talking about introduction of newer molecules, particularly the 1HP, which is a game changer, we believe. And then we have pushed in a few recommendations regarding TPT, particularly rifamycin-based TPT and antimalarials. That is something new to look around for. And, you know, when you receive the document, you also see something which we have included on human rights, ethics for TPT. That is, you know, also something worth looking out for. So there's several new things, but by and large, we haven't deviated much from the guidelines that you are used to. Now, I see there's a hand from TI, or is it T? Please go ahead with your question, comment, or contribution. TI?
Yeah, I'm here. Good afternoon, team.
Good afternoon. Please go ahead.
Yes, I've got a question. In an instance where you have a patient who was on treatment for TB, okay, so this patient has a TB, is actually TB active and has completed ATT. After how long would you consider to give this patient or such a patient TB prevention? I submit, thank you.
All right. Thank you so much, TI. Patient who was on ATT and then they did complete their treatment. After how long post the last TB treatment should they be given TPT? Thanks for that question. We'll take note of it. And then there's a hand from Gupe Kaoma. Gupe?
Yes, thank you, Dr. Singini. I have two questions. The first one is on how frequent someone can take TPT after exposure to someone with a bacteriologically confirmed TB case. I can give an example. If someone was in contact with someone with TB, let's say this month, then afterwards, after they finish taking TPT, again, maybe 3-4 months later, they get exposed to someone with TB disease. Are they eligible again for TPT? So something in those lines, how frequent someone can be eligible for TPT after exposure. Then the second one is, I don't know, I didn't clearly get the explanation on the co-administration of 3HP with DTG. I don't know if it's 1HP that the doc mentioned to say that it shouldn't be co-administered with DTG. So I need a clarification on that, if it's 3 HP or it's 1 HP she was talking about. Thank you, I submit.
Thank you so much, Bupe, for that. Dr. Kagujje, would you like to provide the initial responses to the two questions?
Yes, please. And before I get into that, I would like to respond to an interesting comment. Please note that rifampicin shouldn't be given to pregnant women. There is currently limited data. There's a question on rifampicin. There is currently limited data on its safety, so we shouldn't give it to pregnant women. So now switching back to the two questions that have been asked. One is a person completes TB treatment and then they have contact to a TB case. Dr. Singini, am I right? Was that the question?
Yes, that was.
Okay, so please do take note that even after completion of TPT treatment, we treat with TPT based on the exposure and the risk. And even if a person has completed TB treatment, if they have a new risk to TB, they should be given to TPT. However, do take note that these things, as we've said, we always need to look at the risk versus benefits. If this is an adult person and you have access to testing for latent TB infection, please go ahead and test before you initiate the TB preventive treatment.
Right. Thank you so much. And really just to emphasize, because we had a similar question in the chat box from Blessed Maybin, who was asking about how often then should we repeat TPT in individuals that have previously received the course of TPT. So remember, in people living with HIV, the program has opted that every 3 years from the last course of TPT, the cycle of TPT needs to be repeated. That's in people living with HIV. However, you have seen that we are introducing emphasis on TPT in HIV-negative individuals. So like was mentioned in the presentation, risk versus benefit analysis comes into play after one's completed course of TPT. And so we need to assess for the previous documented exposure to bacteriologically confirmed primary TB before we can consider the TPT. And where resources are available, like was mentioned, let's do our IGRA or our TST. I'll give you a scenario. If I have an HIV individual who completed his course of TPT while he was working as a health worker and then moves to, Monde, where I currently am, and settles on a farm and doesn't have any exposure to someone with bacteriologically confirmed TB treatment, would you really consider giving them TPT? The answer would be no. And so the emphasis there is that we need to do it on a case-by-case basis, depending on the level of exposure and the risk that is attributed to that individual. Now, I've seen there were two hands which have dropped. I think one was from an individual name. I think one was from Boyd, if I'm not mistaken. The hands have been lowered. But if you still have that comment or question, please push it through.
Maybe Dr. Singini, may I respond to the second question from Bupe? So
right.
there was a question on, a request for clarification on 3HP, 1HP, DTG, and TAF. So if you paid attention to the slide, the rifamycin-based regimens will activate cytochrome P450, but to different extents, and this is more pronounced in with the rifampicin. So if we are using rifampicin, the extent to which the bioavailability of the DTG and TAF is reduced does not warrant us to double the dose. So if your patient is on 3 HP or 1 HP, you don't have to adjust the dosage of DTG and you can comfortably give TAF. But if your patient is on rifampicin and isoniazid, you may remember that that's also an option for TPT. We don't use it much, but it's also an option. Then in that instance, if a patient is on DTG, you will have to double the dose of DTG, but don't give it for patients that are on tap.
Right. Thank you so much. Boyd, I see your hand. Please make it quick so that we wrap up our presentation. Boyd, please go ahead.
Thank you very much.
Yeah.
Good afternoon, team. Bad network here. Hope you'll be able to get me. So I have a client that I've sent to the lab, Handa Kapili. This client is on TPT for about a month plus, and then he is now presenting with the productive cough. So I've not, up to now, I'm still seeking for decision whether I should interrupt the treatment for TPT. The client is HIV positive. And then the other thing is, I don't know whether it has been asked or not. I wanted to know, after giving 3 HP, when next should we give 3 HP to a client?
Thank you, Boyd. I think we'll take Boyd as the last person to ask a question. So the question is, he has a client whom he's waiting for TB results, I'm assuming, to be shared. Then this patient is on TPT and has developed signs and symptoms of TB. What should be the next course of action, whether to stop the TB treatment or not? Dr. Kagujje, would you like to speak to that? I can't see the other experts on the call. I think they may have dropped off.
So yes, please. So do take note that we do have some patients that may develop breakthrough TB while on TPT. Much as it's rare, it may happen. If you have a patient that, so what you've done is the correct thing. A person is on TPT, every time they come through, you screen them for signs and symptoms of active TB. Now, in this instance, you've established that they have the signs and symptoms. The next appropriate step is to stop TPT and fully evaluate them for active TB. So based on that, on your results, then you'll make a decision to either reinitiate TPT or to treat for active TB. So always take note that when you have symptoms of TB, remember people with latent TB will not have symptoms of TB. So when you start to see symptoms, then you start to think about active TB. And when you think about active TB, you cannot have the patient on a suboptimal regimen, which could be 1 or 2 drugs depending.
Right. Thank you so much. And I saw a very interesting comment, which I think will be the last one we'll respond to. Someone was asking, you spoke about malaria and the rifamycin-based treatments. What about patients that are on quinine? Should the treatment be discontinued or not? So maybe in the interest of time, allow me to quickly respond to that. And our guidance is speaking to artemisinin combination therapies for malaria. And artemisinin combination therapies, as you may be aware, are drugs where drugs like artemether is derived from, and this is one of the active pharmacological agents in Coartem combined with lumefantrine. So it's those categories of drugs, your artesonates, your artemether, are the ones that we are recommending that you prioritize treatment of malaria with those. But in an individual with quinine, there hasn't been any significant documented interaction between rifampicin or rifampicin and quinine. As such, if you have a patient on quinine, the two can be co-administered. But please do monitor the progress of the patient. Whatever the case, precedence goes to treating the malaria before the TPT. All right, Dr. Kagujje, your final remarks. We are past the hour mark as we wrap up.
And thanks a lot, David. So this was interesting, and certainly the guidelines will be shared with you soon. As David has said, there haven't been so many changes, except the new molecules we have available and clarification on different things. And we don't have much departure from the previous guidelines. Just allow me to say that we are not giving TPT to people who have previously completed treatment if they have no new indication. So take note, we are not going back to the old guidelines, but what we are saying that if they have a new indication and they've completed TB treatment, assess and initiate TPT as necessary. Thank you. Over.
All right, thank you, network. It's been a great conversation. Looking forward to having you next week when we will be discussing another exciting topic. It's good to see our colleagues from Luunga District Health Office joining the call. Thank you so much. It's been great having you on the call, and several other people that have joined in on the call. It's been a very interactive session. We have enjoyed the questions, the comments, and the discussion so far. Otherwise, have a pleasant week. Wishing you the best, and let us address all things related to TB without neglecting the other diseases of public health significance.
Sorry, David.
It's an announcement.
Yes, Dr. Singini. So just to inform the network that we will be having an echo launch for the long COVID echo this Wednesday between 12 to 13 hours. So I encourage everyone to join that particular launch. We have Professor Lloyd who will be launching that program for us. Thank you. Over to you.
Thank you so much, Etta. Looking forward to that. And also an announcement that we have started the TPT surge nationwide to try and bridge the gap in TPT in under 5 children. So encouraging everyone on this call, in whatever role you play, that we identify as many children eligible for TPT in that age group. And also we prioritize the use of 100 milligrams isoniazid, which our current stock status indicates that we have a short or a narrow expiry date for that commodity. So please, let's prioritize the 100 milligrams INH. For facilities that don't have those with a short expiry date, please contact your provincial pharmacist so that we can redistribute these commodities and prioritize their use before they are wasted. Otherwise, thanks for joining us. Have a good one. Bye.